Hi and welcome to Policy Unpacked, a podcast by Global Policy Network. In this series, we dive into the policies shaping our world, from healthcare to sustainability to education, and explore how these critical areas intersect to drive meaningful change. Whether you're a policymaker, practitioner, or just policy curious, we're glad you're here. Let's unpack policy together. My name is Ameneh Saatchi. I'm the CEO and founder of Global Policy Network, and today I'm excited to be joined by two of our advisors and associates, Shilpa Shah and Stephen Riley, as we discuss our latest policy report, the potential of scaling independent prescribing in community pharmacy, which is based on the findings of our second roundtable of the same name, which we held earlier this year. Shilpa is the CEO of North East London Local Pharmaceutical Committee and a frontline leader with over 25 years of experience in community pharmacy and the chair of the roundtable that informed this report. Stephen is the Deputy Regional Chief Pharmacist for Pharmacy Integration at NHS England North West, bringing his perspective of a senior NHS leader responsible for regional implementation. Hi Shilpa, hi Stephen, thank you for joining us today. How are you?
Good, thank you. Thanks for having us on.
I'm really good, thank you. Really excited to be with you again.
So, Shilpa, let's go to you first. You chaired the roundtable, and in your foreword, you wrote that the profession is ready, but the system needs to keep pace. The report identifies trained prescribers without funded roles as a key failure. From your vantage point, what does the system lag reveal about how the NHS is underutilising its community pharmacy workforce?
Yeah, I think obviously having worked in the community pharmacy arena for over 25 years, I do feel sometimes we are an afterthought. I feel that we sort of have all these great ideas within the NHS and we think, oh yeah, who's going to be able to do this? And we talk about primary care and we instantly go to GPs. And whilst everybody has a role to play, we know how overwhelmed they are with workload at the moment, with, trying to make sure that they can fit everything in that they need to. But actually what we have got across England is 10,000 units, 10,000 practices that are on the high streets, that are open evenings, they're open weekends. People can walk into, you don't have to make an appointment. And in each one of those, legally, you have to have a pharmacist on the premises. So where you've got 10,000 pharmacists that you could use nationally to really help people, why are we not using that? And then there's also you've got obviously services that you can go into, but what we have got is a whole cohort of independent prescribers that are going to be coming out in July, August 2026, and we haven't quite forged work for them to do in community pharmacy. And so there's two parts of this. There's one, we've got a cohort of staff that are pharmacists that are willing and trained and able to do things. And the second part is if we've got nothing for them to do, we will lose that workforce. So from a workforce point of view, it's not good either. So I definitely think that there is more that needs to be done. And I know there's work going on in the background, but for me, I just want it to be a little bit quicker and hopefully in place for July 2026 at the latest.
And Stephen, the report frames the challenges not as a lack of clinical capability, but as a structural failures in commissioning, supervision, and workforce planning. As a Deputy Regional Chief Pharmacist, where do you see the greatest alignment or misalignment between this report's diagnosis and the current priorities within NHS England's regional teams?
Yes, it's. I think actually, to some respect, there's a good level of alignment in terms of what's been helpfully framed as the challenges for the system. And as Shilpa's outlined, it is what my role is obviously of a significant leadership role around community pharmacy service, commissioning, delivery, and oversight. And sometimes we can feel a bit like the Cinderella service of the NHS and primary care. I'm always a big staunch advocate, and I've got fortunate to have senior leadership colleagues. Our primary care medical director, for example, who's a GP, is a strong advocate that pharmacy is part of primary care. There's 4 disciplines within primary care, but the traditional approach has been to go to the GP practice elements when you talk about primary care. So a big element really is working towards ensuring that there's key commissioning structures in place and then commissioning intentions to support and utilise community pharmacy services. We've had the recent expansion of community pharmacy clinical services in the last 5 or 6 years or so. We've expanded the community pharmacist consultation service to become Pharmacy First, using delivery PGDs. We've had a national contraception service, which has just been expanded to include the emergency contraception arm. And we've now had expansion to an NMS service to include depression, which is a fantastic area of support for patients. If we look at the NHS 10-year plan, there's a significant shift to prevention away from treatment and community-based care from hospital. There's a huge role for pharmacy and community pharmacy in that shift and that delivery. Also, recently we've had the medium-term planning frameworks being published, which outlines the plans for the next 3 to 5 years. And there's very, very clear prominent role for community pharmacy directly named within that planning guidance. We're expecting that ICBs will support and commission services through independent prescribing through community pharmacy, better utilisation and better delivery of clinical services through community pharmacy. So certainly the commission intention is there. I do appreciate we have significant challenges around helping train up and skill up the existing workforce to expand our independent prescribing capacity. It's not through lack of willingness, and there's actually funded places available for people, but there are challenges in accessing designated prescribing practitioners who can give the supervisory support, help train up our colleagues. There's certainly work to be done around peer support, and we've done a lot of work with the independent Pathfinder programme, prescribing Pathfinder programme through community pharmacy, which I know Shilpa's region has been a key part of as well as our region in the Northwest. Key learning from there is the peer support, the mentorship has been really key, some of the key findings, and that structure needed to support pharmacy delivery. There's a huge amount of work gone into looking at the logistics and how that will work in reality. And there is a significant body of work being delivered in parallel to what will have to go through the negotiation approach to get pharmacy services fully commissioned on a national basis. I know that work's underway. Myself and other senior colleagues are part of those work streams, shaping the national policy and programme, looking at everything from the logistics of how an ICB does quality oversight support, brings pharmacists in as non-medical prescribers, right through to how we do the logistics of setting up prescribing cost centres, how it's funded through the Business Services Authority, how we ensure safe and effective practice, and the digital elements around systems to enable pharmacists to prescribe, and they can have their own records and things of that nature. It's a big piece of work, trying to work with system suppliers to develop integrated systems over the next couple of years to enable pharmacists to have those systems set up. And there's a lot of work being done to support the workforce through our workforce training education colleagues, help skill people up to in their prescribing competency and availabilities. And a lot of work is being done to try and support and ensure we will have work for our prescribing colleagues to deliver when the newly qualified pharmacists start from next summer onwards, to make sure there is roles for them to do. And Shilpa's quite correct, if there's nothing for them to do, we will lose into other sectors. So whilst there are significant challenges, I think it does align well with the work streams that are underway. The big challenge will be how quickly we can get things through, and also working the very tight constraints of resources. We had the budget yesterday, and there is very much a restrained resource available for NHS services, for pharmacy services, but we are working to try and make sure we get as much as possible to support our teams and colleagues.
And let's now look at some of the international lessons and national solutions that were mentioned in the report, such as the Scottish model of funding structures, New Zealand's model of technicians, and Australia's supervision hubs. From your perspective, Stephen, which of these do you think are ready for us to implement now, and what is the next step to piloting it?
So I think key elements, particularly around the Scottish model and what's being done in Wales in terms of current use of prescribers and community pharmacy, have certainly been key learning points to shape and inform our policy. I think one thing which not everybody appreciates is, why can't we just do what Scotland does or Wales? If you look at the size of the geography and the population we serve in England, effectively the whole of Wales is almost like one of our regions. So the ability to shape that up and to scale that up across the whole of England is a much bigger challenge. It's not just a case of let's adopt that model and bring it over here. Having said that, we are taking key learnings from the structures, the processes, and the governance side of elements. All of that has been instrumental in feeding into the independent prescribing Pathfinder pilot, which has been a significant piece of work we've delivered over the last 18 months through community farms. We've had a huge amount of learning from this process to understand how we could potentially fund pharmacies, looking at different clinical models, what types of work the pharmacy teams could support, be long-term condition management, acute care with extended minor illness, medicines management and medicine optimization services, de-prescribers. We had a whole array of clinical models tested out. We've also undertaken a full evaluation with the University of Manchester and other colleagues to give a full academic evaluation of the whole programme to understand the key learnings and recommendations for what we need to shape up and scale up to deliver a prescribing service. And I know now colleagues from a policy perspective are taking learnings from the programme and from other systems to shape what type of models we may commission, what we may commission at national level, and then how we maybe support our integrated care boards, and particularly in their new role of fully responsible for primary care in the new NHS structures, how we support them to commission services for their populations. Also, if you're looking at, as you mentioned, things like supervision models and use of pharmacy technicians, in the last 12 months or so, we've had an increase in the use of pharmacy technician availability and being able to work to patient group directions. So we've expanded our community pharmacy services to enable pharmacy technicians to take a bigger role in delivering those services as autonomous health professionals, which again has really helped skill up our pharmacy teams and free up the pharmacists to do independent prescribing roles and all the more clinically focused services. So that's another been a key learning element. Work's underway currently just to finalise the introduction of hub and spoke dispensing models, and we've got a consultation at the moment looking at how we can alter and amend pharmacy supervision, again to free up pharmacist time, but also make better use of our skilled workforce and all the professionals like our pharmacy technician colleagues. So we've certainly taken a lot of learning, and there's a number of things now that are actually in train actively or have actively been piloted, and we're just working through that process of shaping the policy and going to negotiations. So it's been really helpful to bring those key elements into the process.
And Shilpa, a powerful quote from the roundtable was, "Our value lies in not being boxed in." The report warns against restrictive service models. How do we design a national commissioning framework that provides consistency and safety while also allowing for the local flexibility that makes community pharmacy so vital?
Yeah, I think the thing is with community pharmacy, we are based in local communities, and every community is different to its neighbouring community. And we're actually, as in NHS, we're now looking at neighbourhoods. And what I think would be really useful is to have this framework where it tells you sort of, I guess, all the different areas in which you can prescribe in community pharmacy, but leaving that quite open. So not being like, to talking about asthma as a whole, talking about cardiovascular as a whole, not cardiovascular, but actually we can only do cholesterol, cardiovascular, we can only do blood pressure. So almost having some key areas that we know is affecting the health of the nation and that we know that are in high volumes. And then what we could have is almost as part of that framework is kind of what are the good IT tools to use so that we, it doesn't have to be the same IT tool. We do need competition out there on the market, but actually these are the 5 recommended IT platforms that you can use for your prescribing. And a real kind of an SOP almost on, this is, you have your consultation. Once you've done the prescribing, making sure that you go to the GP and any other healthcare professional and having everyone follow that, but just not boxing in on saying this is the only condition you can prescribe for, which is a small part of a bigger long-term condition. And I think that's absolutely right. We've been doing that in our IP Pathfinder sites, which is the right thing to do because we're testing and we're checking and we're looking. But I think going forward, what I want to be able to say is in Tower Hamlets, we know that cardiovascular and diabetes are 2 of the biggest things that affect the population. So I'd like my pharmacies in Tower Hamlets to be able to really delve deep into that and kind of go, right, actually, we're going to have a service for any person living in the area that's going to be able to come in, get their HB1AC checked and have a real program of what happens to them. So it could be that they're not actually diabetic or likely to be diabetic, but what happens next? Are they on the borderline? So what kind of advice can we give them? So it's got to be a real wraparound service, not just you come in with this condition, we prescribe something and off you go, because actually we really want to de-prescribe as well. We shouldn't just be looking to prescribe, we should be looking to de-prescribe. There are so many people out there taking medications that were put on their prescription years ago. They probably don't need it anymore, but nobody's really actually had time to review it, or the patient doesn't want you to take it off because they don't really understand, but having that conversation. So I think de-prescribing should also be kind of not a condition, but an area where we can focus. So that's what I'd like to see going forward.
Thank you, Shilpa. And Stephen, the report identifies the pharmacy technician workforce as critical to freeing up the pharmacist's time. So from a national workforce strategy angle, how do we make the technician role more attractive to people looking for a career in healthcare?
I think a key element of this is we wanted to recognise we're now in a position with pharmacy technicians where we've really got the opportunity to enable them to work as health professionals in their own right. So whilst yes, obviously community pharmacy still has a requirement to have a responsible pharmacist and overall responsible for what happens in the pharmacy, this is the first time now working through patient group directions, through other elements that pharmacy technicians can actually go and deliver direct patient care as a registered health professional without a need to have another health professional physically checking like the medication before it goes out to the patient, like we do in dispensing. They can supply medicine through a PGD. They can provide a vaccination service through a patient group direction, which gives that real opportunity for them. So I think it's key to capitalise on this and build this into developing a professional identity for pharmacy technicians in their own right. One, on a personal basis, I've never thought it was a fantastic thing when the General Pharmaceutical Council used the collective terminology of pharmacy professionals to describe pharmacists and pharmacy technicians. More for me, because I think we do different functions, different roles, we have different qualifications. I think this is now a great opportunity for actually to really develop an identity for our pharmacy technician workforce and colleagues. I think there's a key, we need to do this in conjunction with the regulator, with workforce training education colleagues, and also with professional leadership bodies like the Royal Pharmaceutical Society and the Association of Pharmacy Technicians UK. But I think that'll be a key element to this, and then we can really then try to sell to people the concept of a health professional career pathway as a pharmacy technician. There's also fantastic opportunities for them to work across different sectors as well. In the profession, there's better utilisation of pharmacy technicians' roles in GP practice settings. They're all well used in their hospital care settings as well. So there's a fantastic opportunity to really develop a brand identity professionally, highlight some of the key things that pharmacy technicians are able to do. With the supervision consultation, it's likely they'll be able to undertake a greater level of supervisory roles in a pharmacy setting as well. So really outline that to colleagues about how they could pursue that as a career pathway within a pharmacy setting, and it gives it's another route to be able to develop and have a full fulfilling career as well. So it'd be a really great opportunity there for us.
Absolutely. And Shilpa, from an employer's perspective, what one change would most improve the technician recruitment and retention from your perspective?
I think there's actually two things I'm going to say here, not just the one. One's got to be something around funding. So there are funded places for pharmacy technicians, but the number is very small. And I think if we had that sort of almost like apprenticeship funded places, then I think that would really help increase the workforce. But I think then it goes back to the retention. So the retention side is often because, you've got this amazing skill, you've got this training, you're now a registrant on the GPHC register, but actually you haven't got much to utilise it in. So it's also how do we train up our pharmacists to be true leaders and understand that it's okay to delegate to a pharmacy technician, obviously making sure that they're competent, etc., but really supporting them, because there's some people out there that just want to do great things, but if they feel that they're being held back, they may move into other roles where they're given a bit more autonomy. I would also say yesterday with the news with the budget, I think that we really need to look at community pharmacy in particular as being a healthcare provider that, yes, we're on the high street, but things like an increase in the minimum wage is going to hit our contractors really hard. And whilst I understand that minimum wage is set for everybody working out there in employment, but there are things like, business rates. As a healthcare provider, 90% of our business is NHS. So could we look at maybe doing something differently with business rates and making pharmacies exempt or pharmacies that offer, 60% of their business being NHS or more can have lower reduced business rates. I think that would really also help generally the workforce. And that's actually the most noise that came out yesterday from our contractors about the budget.
And let's now delve into the path to integration and cultural change. So, Shilpa, the report notes that collaboration with general practitioners is inconsistent and that cultural changes is the hardest nail to crack. Beyond just sharing records, what concrete actions can be taken to build the trust necessary for pharmacists and GPs to see each other as genuine clinical partners?
Yeah, I think there's, again, two parts to this. I think that one of the things that we should be doing at a national level is aligning the contracts so that they're not competing for the same patient. It's almost like, actually, this is a patient, this is what GPs can do for that patient, and this is what community pharmacists can do. So that patient gets the best of both professions and both professionals. I also think there's a big part of when GPs are doing their training, it should be almost mandated that they spend 2 weeks in a community pharmacy, and vice versa when trainee pharmacists are doing their training. And we're doing that now, actually. We're going to have some multi-sector placements for trainee pharmacists in the next few years that are actually going to be mandatory. But we're not quite there yet with all GP professionals. And what I would really urge everyone out there to do is just pop along to your local GP practice and start talking to people, because, you know, going back to when I qualified years ago, it was just something we did. And you had that, you know, GPs understood that we were the experts of medicines, and we understood that they were the experts in, I guess, diagnosing and prescribing those medicines. But actually things have moved on, and I'm not quite sure that both sectors have moved on as much. So, you know, GPs do a lot of different things now, and so does community pharmacy. So it's about having those, you know, informal networking groups as well, that we're not so you know, siloed in that pharmacy do their thing and GPs do their thing. Let's start mixing things together.
And Stephen, the NHS 10-year plan is a central theme in the discussions of the report. In order to achieve its ambition, what is the single most important measurable commitment we need to ensure the pharmacy profession is working to the top of their license?
I think for me, the key element with it is it links back to the integration elements. If we can proactively ensure that community pharmacy services are integrated into care pathways at ICB level and a neighbourhood level as part of a primary care offering to patients. So it's clear to people what the services are available, what they deliver, how they're utilised, and we utilise then those pharmacy professionals at the right time in the right setting as part of that patient pathway and journey. That will ensure then that there's a legitimacy then to support referral into those services and utilisation of those services from other health professionals, particularly GP practice. And I fully agree with Shilpa. I think relationships is absolutely key there for that, to have that confidence. But it also has the legitimacy, it's an expectation of a patient as part of that pathway for that condition or those group of conditions. They will be seeing a pharmacy or going to a pharmacist to see that professional, or even a pharmacy technician, depending on the services, for part of their care. And that way we've not got the point where pharmacies are reliant upon trying to grab patients as they walk in and try and add additional services on, or they're not just reliant on a goodwill relationship with the GP practice to do some referral. By having them as part of that care pathway, it really helps give a legitimacy to the service, and it shows the importance that the commissioner places on the services. And then I think that will enable them us to utilise our pharmacy professionals to deliver care to the best of their ability and the top of their competency. I think that will be really helpful in helping driving that forward. And then it obviously underpinned then by those conversations, relationships at pharmacy to GP practice level, at neighbourhood level, and really supporting that process and making sure then we've got patient-centred pathways and people are part of that journey and part of the pathway at the right time with their right skill set. And then supported to deliver the best patient care and also to develop within those pathways. It also actually links very well to we had the roundtable at the local pharmacy congress last week, of looking at care pathways of cardiovascular, metabolic and obesity. I think looking at those type of conditions, how we treat a patient holistically and put the patient in the centre would really help us then have pharmacy professionals utilised to the top of their abilities and competency.
And Shilpa, the report concludes that independent prescribing is an actionable reform. From a policy perspective, what is the most effective lever to create immediate momentum, and what can the Royal Pharmaceutical Society or the associations do to support their members?
I think the first thing is working on that framework. If we can get that framework in place and allow the current independent prescribers to be able to start using that, then I think that would be the first step. I think that there's other bits that need to be done almost in conjunction. So you almost need to make sure that we've got DPPs. As Stephen said earlier, there's a lot of funded places, but we haven't quite always got the DPPs to go with them. And a lot of those funded places, they are now, but a couple of years ago weren't even being fully taken up, were they? So how do we get the legacy workforce trained as well? But I think we also need to look at, nationally, we need to look at funding. So we need to make sure that there's funding for this. It cannot come out of the current funding system that we have already, because, and I'm talking about the global sum for community pharmacy, we just, excuse me, don't have enough money for that. And I think also we've got to think about our premises and consultation rooms. So what we really need is an injection of cash almost from the government to kind of go, this is what a good consultation room looks like. Here's the funding for you to do that. And at the same time, do your training. So it's not just the one lever, it's almost lots of different things in conjunction. But what we need is all our leadership groups is to work together. So you talk about the Royal Pharmaceutical Society, soon to be a college. They need to be working with the, Royal College of General Practitioners and helping them understand that this is a benefit, it's not competition, and that we can work together. So they can be doing a lot of the background work so that when we do start doing these services, we don't get that, negativity from anyone else kind of not fully understanding what we're doing and why we're doing it.
And Shilpa, talking about leadership, so your roundtable brought together 21 diverse leaders. What was the most compelling shared message from that room that you believe should be the main takeaway for pharmacy leaders now?
I think the main message is that people want to do this. People want to develop their skills. They want to increase what they can do to help their patients. And that we've got the energy, we've got the enthusiasm, we're getting the trained individuals. So, everybody's asking, what's next? How can I make this happen? And how can we make it happen on the NHS? Because we obviously get a few community pharmacists prescribing privately, but how can we make this happen? How can we make it in scale? So for me, it was the energy, the enthusiasm, and the, we want to do this. Can you help us to make sure that we can do this?
And Stephen, the report presents a clear start, stop, scale framework. As a senior leader, what is your personal priority from that list from the Northwest region in the next 12 months? And what support do you need from the centre to achieve this?
I think a key element really, we need to stop the approach. I think this comes up on a regular basis, and I think a lot of leaders say it's the siloed working approach, but having community pharmacy over here, general practice over here, other NHS over here, and it's not, rather than being a disparate service offering, which is really helpful. It's again, how do we put this as part of care pathways? So how do we utilise what we have and what's commissioned to directly support patient care? And that's one real key thing. We've got some pockets of good practice where it's starting to happen. I know my region, we've got some of the care pathways where pharmacy services are featured or mentioned. I wouldn't say they're fully integrated, but at least they're partly included in that respect. And I think until we actually have that approach, we fully include them and integrate them into a primary care service offering for our patients, and which is built around the patients and geared towards achieving some of the ambitions from the 10-year plan, we're not going to achieve what we need to. And also because we're in a situation, we've heard the budget yesterday, we haven't got a cavalry run over the hill with a magic money tree and bags of money. We need to best utilise what we have available, the services that we have commissioned, and utilise them for our patient care and get the most outcome. But also inevitably, if we can do that in an effective way, it will also help us then to actually support a sustainable funding approach and model for our community pharmacy contractors. So then, rather than piecemeal bits of service and patient population popping in and out and getting bits of service here, there and everywhere, they're actually supported, excuse me, and they know what workflow is going to come through, they know what rough idea what patient numbers coming through. That will enable them to get a better idea what income they'll have available. They could then potentially look at, can I invest in my workforce? Can I invest in my premises? If I know I'm going to need to have additional consultation rooms and I'll be able to get the services to fill them, they give them confidence and ability to make that investment. Without that, it's very difficult for them to actually invest in their premises and make themselves more fit as healthcare environments to support the patient demand needed. And I think obviously from the centre's perspective, a key thing we need from this is proper review and support to look at how we commission services and how we fund them. So if we can move away from a pay per service delivery and pay per patient interaction to more of a funded by outcomes, and as Shilpa outlined before, if we get to the approach where we better align the contracts between different primary care contractor groups. So rather than being in competition, we're in that time of the season now with vaccinations are very being delivered quite regularly. It's a vaccination season, influenza vaccinations, COVID vaccines. We always have that bum fight between some GP practices and pharmacies because they're my patients or they're my patients, my business. And we've got a lot of people, great examples of collaboration, but we always have that argument, tension between the two. And this again, so we can move away to maybe supporting contracts that will actually commission service in a way where people are funded for patient outcome delivery, so sort of deliver and prepare for a patient population. I think that'll be one key thing. I mean, one example you've got from my own personal experience, I'm sure there's all this with no GP practices. You may go for certain services at your GP practice, but you'll find one GP practice in a PCN footprint will look after certain service types, either minor surgeries, women's health, other bits. So you may not go to your direct practice, but you'll go to another one in the PCN who will deliver that for the whole group. If we can get an approach where community pharmacies are able to deliver services across a neighbourhood in that way, and either in conjunction with other people like GP practice for patient outcomes, so they're all funded for delivery of patient care as a whole, it really helps take away some of that competitiveness, which we probably isn't most beneficial to conducive patient care.
Thank you, Stephen. And Shilpa, finally, the final question over to you. So if we were to reconvene in a year's time, what is one concrete, tangible change we will be able to report that demonstrates real progress in scaling independent prescribing in community pharmacy?
I'd like to say that in a year's time, if we were to meet again, we would have a framework associated with like commissioning, so it'd be a commission service for any pharmacy that wants to do this, that there would be a suite of services that community pharmacy could offer as independent prescribers. That's what I'd like to see, yeah, fingers crossed.
Fingers crossed. So thank you, Shilpa and Stephen, for a deeply insightful conversation that moves this critical report from page into the realm of action. The roundtable has spoken, the evidence is clear, and the path forward is mapped. It is now a question of leadership and will. So thank you to both of you for joining us today, and to our listeners, you can download the full report from the Global Policy Network website. Thank you for listening, and see you next time.